Well, what is important in this case is that one of the questions which came was about the clinical correlation about the ascending tracts, particularly that's what we call the tabes dorsalis or tabes dorsalis, which is in case of the Snell. Although I didn't talk about that, but if you're asking me, I will go through it and I will explain why. In case of Snell, some things which if I'm not explaining, most commonly it means that either you will cover it in case of neurology or the information which is in the part of a Snell is really very scarce. But as the question came for that, let me explain that portion. Just a second, please. I just will open where it is and I'll show you. Oh, second. Not this one. Background secured. No, just a second, please. Well, here we do have part of a tabes dorsalis. Well, to start to talk about that portion, let me tell you one important thing. That this particular condition is mainly associated with the infection. And this infection is the one type of the sexually transmitted type of a diseases. This is the syphilis. So in the case of the syphilis, yeah, here it is. So in the case of a syphilis, we do have the several stages of the syphilis, and one of them is the last stage, which is the neurosyphilis, and its condition, what we can see in this case, this is particularly tabes dorsalis. How it is associated with the tracts is that particularly in this case, we do have the lesion, most commonly, of the dorsal columns mainly, rather than any other parts. And the problem here is that we don't know why, because this tertiary or neurosyphilis, which is starting, most commonly starts like after the infection, like approximately in 20 or 30 years even. And the most interesting thing that we cannot even find the part of the syphilis itself, but it is associated most commonly with the patients who were having the syphilis. Now, what is happening in this case is that they tell you that the organism causes a selective destruction of the nerve fibers at the point of entrance of the posterior root into the spinal cord, especially in the lower thoracic and lumbar sacral regions. Yes, that is partially precise. Let's say that. Sure, it's correct, but it's not that much precise. The idea here is that when we talk about the tabes dorsalis, first of all, we call it the progressive demyelinating type of a disease. Demyelination. Yes, it's not literally a degeneration, yes, of the nerve fiber, but this is the degeneration of a myelin sheath. And most commonly, it is associated not that much with the thoracic region, to be honest. It is mainly associated with the lumbar region rather than the thoracic one. And what is happening in this case is that particularly the dorsal aspect of a spinal cord and even some part of a spinal roots there are mainly undergoing the demyelination. And the problem here is that when we do have a demyelination, look what is happening. You remember from the one of the explanations, yes, that and it was in the physiology in the Guyton. I was telling you that the whole dorsal root, yes, we can subdivide into two main parts. Do you remember that? Where I told you that we can subdivide it into medial parts or medial fibers and lateral fibers, yeah? and particularly in the case or medial division and the lateral division of the fibers. So in the case of a medial division, which was closer when it was entering towards the dorsal horn, these are the structures which are propagating the proprioception and the touch mainly, yes? The ones which are more laterally localized, these are the ones which are the fibers of the pain, of the temperature, and so as a result we can even subdivide that the fibers of a dorsal column medial and meniscal pathway are more associated with the medial division, and as a result it's more even posterior, yes, rather than the part of a lateral division which is more associated with the spinothalamic information. So why I'm saying that? Because in the case of a tabes dorsalis, the posterior regions are the ones which are the mostly demyelinating. So the part of more medial division, as well as the portion of the dorsal columns, they are the ones which are undergoing the demyelination. As the result, what they tell you here is that what are the symptoms? You see, there are many different types of symptoms, and let's go through them because they are very, let's like that, controversial a little bit, you know? Look, they say that the signs and symptoms here are stabbing pains in the lower limb, which may be very severe. And then it comes the paresthesia, so the numbness literally of the lower limbs, some hypersensitivity to the touch, heat, and cold, and so on. So the question was, if we do have here, as they told us, the destruction of the nerve fibers, yes, at the dorsal root. So how we can have the part of a stabbing type of a pains and some hypersensitivity? That's a logical question. But as I told you, mainly it's not the root that much itself, but that much the part of the dorsal column which is undergoing the demyelination. As a result, to be honest, all of these large amount of different types of the symptoms, we subdivide them into three main. One, as it is written here, this is the paresthesia. So when, sorry, so when particularly we have this altered sensation to the touch, to the vibration, to the pressure. So as a result, in this case, it most commonly it's a lower limbs because we're talking about the lumbar region here. Yes, as you can see, that's why this numbness, this paresthesias are mainly felt as the part of a lower limbs. So what is important also here to emphasize is that one is the paresthesia, but the second thing, what is most interesting, is that the part of the pain. You see here, they tell you that we still have a stabbing pain, yes, to the lower limbs. It is associated with this portion. Look, hypersensitivity to this of the skin for touch, heat and cold. So it means that because mainly the tabes dorsalis, because of unknown cause, is mainly demyelinating the dorsal columns, you know, that's why the part of the spinothalamic pathway, which is mainly seen on the lateral portion of the white matter, is not, plus it is not that much myelinated also. Please remember that, yes? The fibers here are much smaller. Do you remember I explained that from the physiology where we had this nice table? I told you that this table is very much important. You remember where we had the subdivisions into that fibers A and fiber C. Do you remember? And then we had the subdivision into the fiber 1, fiber 2, fiber 3, and 4 in case of a sensory type of an input. So if you remember, when we're talking about the pain and temperature, they were very much associated with the smallest type of the fibers because of what? Because they were either not myelinated, yes, or not completely myelinated as the large fibers. So as a result, in this case, demyelination in this portion is not seen that much, and as a result we have the hypersensitivity of the spinothalamic pathway, you know, and as a result sometimes the patients feel even the simple type of a touch, you know, as painful. You see that, and again and again it comes from the lower limbs mainly in this case, you know. So as a result, what is happening here is that again and again there is no necessity of the degeneration or demyelination of the part of the spinothalamic pathway, because most commonly they are this degeneration and demyelination are associated with a part of the dorsal columns, you know. So just simply here we have increased sensitivity. That's why hypersensitivity, that even the touch senses are felt more as the painful type of a stimuli, you know. So as a result, as I said, we have P for paresthesia, second P for the pain particularly. The third P, which you can see, this is the part which is associated with the fourth um, symptom here. This is the polyuria. Like in this case, it means that the increased urination, although it is not associated with literally increased like urinary formation and so on. No, it's not with that. But the problem here, because again, because of the unknown reason, we have here, sorry, the part of the sensory fibers which are propagated from the walls of the urinary bladder, that are having the muscular structure, and as a result they can be distended. This particular distension is not felt by patient, you know, and as a result the patient cannot understand that if the urinary bladder is full or not, you know. And as a result, what is happening that most commonly the behavior, what we can see in this case, either the patients are simply urinate very often, you know, so they don't understand if it is full or not, so that's why they are literally going to the bathroom very often, or vice versa, they are trying to because the portion of the lower motor neuron in this case is okay. Most commonly there is no problem with the lower motor neuron, so there is no problem with the motor function, there is a problem with the sensory function in this case, you know. And as a result they can simply voluntarily control the urination, and as a result sometimes they even let's say like that, avoid the urination very much, and as a result they just, like, you know, simply thinking that okay, there is a large time which passed, they are going towards the bathroom, you know, but not, it's not associated with a part, again and again, with a part of the motor functions. There's a problem with the dorsal region, that's why it is mainly the problem of the sensory pathways rather than the motor pathways, you know. Although now you would say that if you are saying like that, then why do we have here the part of the a loss of the posture and some passive movements of the limbs and so on, as well as here you can see the part of the ataxia, so not very regulated type of the gait and so on. So what is happening in this case particularly? So to be honest, first thing what you need to remember with the part of the tabes dorsalis is that it's not the acute type of a problem, you know, it's chronic. There is the progressive type of a demyelination. As a result, it will start with the several type of the symptoms, and step by step will increase more and more symptoms, you know. So as a result, we can have here, for example, at the beginning, the paresthesias, then there will be some this pain syndromes, then we will have a part of the polyuria, as well as what is interesting here in this case that if you remember when we said about this tabes dorsalis, I told you that there's a problem with the dorsal column. Yes, dorsal column is mainly containing the first order neuron of a dorsal column medial lemniscal pathway. Yes. And these first order neurons, you remember, they are propagating the information not only about the touch, pressure, for example, or vibration, but also the proprioception. Do you remember that? And as a result, the proprioceptive fibers, if you remember, they were also associated with the reflexes. Because although, yes, one part, if you remember, we had the longer and the shorter type of the of the branches, which one was entering towards the dorsal column medial lemniscal pathway and was ascending, but the other one was directly making the synapse with the lower motor neuron. Remember that? And as a result, what is happening? That because of the loss of the proprioceptive sensation, yes, in this case, we do have like the patient cannot, they cannot understand where their lower limbs are in the space, you know? That's the idea of a proprioception, yes, localization of the parts of the body in the space. So most commonly, these patients cannot identify where their lower extremities are, and as a result, because of no problem with the LMN, so lower motor neuron and upper motor neuron, yes, they are walking, so they have the movement, okay? But the movement is not well coordinated. That's why we even can see that in this case, these particular patients will have like, you know, like how to say this gait, that it is more broad type of the gait, you know. So, and as a result, like their movements are not that much, like more clumsy, you know, compared, for example, to the normal type of the proprioceptive function. You see? So as a result, it shows you one more time that not only itself the damage to the motor fibers can give you the problem with movement, but even the part of the proprioceptive fibers which are damaged. In this case, they are also can giving you the problem with the movement. You see? So, and most commonly, you see that everywhere we're talking about the lower extremities mainly, and you can see that unsteadiness of in the gait. You can see, and as a result, mainly what will happen in this case is that they also tell you it is compensated with some extent of vision. You know why? Because here in the tabes dorsalis we have one more sign. We call it a Romberg sign. The Romberg sign means that when, because of the proprioceptive problem, when you are asking your patient to close the eyes, you know what is happening? He or she is standing and swaying, starting to sway, you know, anteriorly, posteriorly, and so on. You know why? Because the proprioceptive fibers are not propagating the information. That's why. And but as soon as, why we say closed eyes, as soon as the patient is opening the eyes, that's why one of the pathways, one of the information where it takes like about the environment, yes, will be simply the visual pathway. That's why they tell you that this unsteadiness is mainly compensated with the help of the vision. You see? So from the other side, if not from the muscular region, yes, because the proprioception is not working, the other way to orient in the space will be the vision. Okay? So that's why they tell you here, however, in the dark or if the eyes are closed, yes, in this case, the patient may even fall because he or she has this swaying type of the movement, even if he or she is standing, you know? Is it clear? As well as you will sure have some hypotonia. So why in the muscles and the joints? Why? Again, not because there is a problem with the LMN or UMN, so upper or lower motor neurons. It's because of the proprioceptive fibers which are damaged. You see? As well as, sure, there will be the reflex activity which will be also decreased or completely absent as the result, as the demyelination goes through more and more. You see the idea? Plus, what is happening in this case also is that we have a very interesting thing. I don't know if it's written here or not, but yeah, looks like not that much. But also unknown, or by unknown reason, we have also the damage to the part of the portion of the pretectal area. Do you remember pretectal area? We studied it just recently. We were talking about it at the level of the midbrain, yes, where we had the portion of the superior caliculi. Do you remember why we needed particularly this? We needed it for the pupillary light reflex, yes, for the constriction of the pupil, yeah, through the cranial nerve 3 with the help of the parasympathetic innervation. So interesting thing that in this case we have the type of the problem which we call the Argyll or Argyll-Robertson pupil. So where particularly on the part of accommodation is okay. I mean, they can accommodate the vision, but the patient. But in a case of the pupillary constriction, it's not happening because there is also damage to the portion of a pretectal area in the case of a tabes dorsalis. So, and this everything is associated with the syphilis. Particularly, we call this stage the neurosyphilitic or late third stage. And as a result, these type of problems can be seen in this case. Was it clear? Good. Okay. Now, what is also interesting for us is that the part of let's go through the descending tracts then. Okay. Let's go through them and let's see then what are the problems here. I mean, in the case of clinical correlations, which I have also uploaded for you. If you remember in the part of like the comparison between the part of a paralysis and the paresis or paresis. If you remember here, I had for you this, it's not like a presentation, but still. So where we were talking about the part of the descending tracts, and here in the case of a descending tracts, we said that, okay, let's also see them here, the part of descending tracts, and let's go through every and each information. What we have in the very much details. Just a second. So what do we see first of all? That anatomically we said that we have how many neurons in order? We have 3 neurons in order, yes? So the part of the first neuron, as you can see, which is, if it's a descending part, a descending tract, we remember that it comes from the cerebral cortex. And from our already knowledge about the cerebrum, we remember that particularly these fibers, in the case of corticospinal tract, they are originating in the primary motor cortex. Do you remember? In the primary motor cortex, we have the formation of this first order neurons as they are starting to then synapse with a second order neuron. And as you can see here, it is internuncial type of the neuron, or we also call it interneuron. And most commonly, you can see that it is associated with the spinal cord and its gray matter in the anterior part of it. Why? Because if you remember, we said that the first order neuron was the one which is one of the longest, yes, coming from the cortex, going down through the part of the whole brainstem, as well as entering towards the region of the spinal cord. And here only it starts to make the synapse with a second order neuron, which is very, very short, yeah, and that's what we call this internuncial type of the neuron. But next, this internuncial type of the neuron, which is the second order neuron, you can see here it is short and it's directly synapses with the third order neuron, which we call the lower motor neuron now. And I told you that also that lower motor neuron is the one which is literally originating from the anterior gray horn, yes? So as a result, whatever we see in the case of the anterior gray horn, this everything is literally can be imagined as the lower motor neuron there. Okay, and as a result, the third order neuron in the corticospinal pathway, this is the one which gives rise to the innervation of the skeletal muscles, as you can see. That's why it is written here through the anterior root and the spinal nerve, because they are the ones which are originating in the ventral or anterior root, yes? So as the result, you can see here that sometimes they tell you that there is in the case of reflex arcs, and that's what we have also seen here, as I showed you in the second one. I do, but no, sorry, not here, not here. Yes, here it is. Look. So where you do have a part of the dorsal root, because this is the sensory fibers, yes, and this is the sensory fiber of the ascending tracts, which is first order neuron also, yes? You see how it looks like? And in this case, what is happening? We can have particularly direct type of the synapse here. That's why in this one sentence, they told you that in some instances, you can see here, we can have the axons of the first order neuron, in this case, the portion of the first order neuron of the sensory pathways. They can terminate directly on the third order neuron, yes? And that's what is seen particularly here very well. That's how it looks like, you see? Okay? So let's continue. We do have here figure 4.19 to see. So let's compare what do we have in a part of a presentation and also here, okay? So this is our 14.9, which shows you the simplified form of a descending motor pathway from the portion of a cerebral cortex to the skeletal muscle, yes? And as a result, they tell you, do not forget that there is 3 neurons in order anatomically. Oh, sorry. Yeah, 3 neurons, sorry? Without it going to the cerebral cortex, what do you mean? You mean the first order neuron? No, that's why I'm showing you. Look, you do have the passage, but also you have a branch which is directly associated with the lower motor neuron. If you will recheck my offline video, you can see that the same. I'm explaining that part, that you have simultaneously the several types of the connections here. And also in case of the a Guyton, do you remember when we're talking about the different laminas, this which are by which we are subdividing the whole gray matter, yes? And where we were talking about the median and lateral divisions. So particularly there, you can also find it, that we do have the parts, so branches, which are still having the synapse directly, but at the same time, they still propagate, the main branch still propagates the information through the ascending tract. You see? That's why what they show you here, coming back to that portion, yes, we have this, the longest type of the first order neuron, or that's what we call simply the upper motor neuron, yes? And this is the one which is passing down through the whole central nervous system mainly. And here at different levels of the spinal cord, it starts to make the synapse with the second order neuron and then the third order neuron. Although clinically we just say that we have the first order neuron, which is upper motor neuron, and the lower motor neuron, yes, which is the third order neuron in reality. Okay? So because like there is, it's very difficult to find something or some clinical manifestation where you'll have only a problem with the internucleal neurons, you know? So that's why either you will have the damage on the upper motor neuron or you will have a lesion on the lower motor neuron, which we will talk about, okay, a little bit later. So as a result, what I showed you also, so what I showed you also here, let's come back to that particular nice picture. So this is the one which is giving you the main idea of the whole corticospinal pathway, yes? So where you have the beginning from the cortex and going down towards the skeletal muscle. The same you can see here, just with the part of the second order neuron which is present, okay? Now let's go down. What do we have in this case? So the part of the corticospinal tract, as you can see, yes, are the pathways concerned with the voluntary discrete skill type of a movements. And particularly it is associated with the limbs there, yes, the distal part of the limbs. What are the distal part of the limbs for us? The most important, the hands, yes, simply. So this discrete type, that's true, Kumar, thank you. So the most discrete type of a movement, we even talked about that in the case of body systems 1. Do you remember? That particularly our hands, and particularly the thumb and the different types of movements that we can do, this is literally showing how highly developed is the human body. Yeah. So this, what we talk, you see, all of these things are mainly associated, like this corticospinal tracts are mainly associated, here we need to say, with the conscious type of the control of the muscles. That's why for now I was very much emphasizing corticospinal, because it is associated with the cortex of the cerebrum, you see, because it is associated with the conscious type of a voluntary control. All right. Now, all of the others, what you see mainly here, starting with the reticulospinal tract, I told you we will cover that with a part of reticular formation, which is starting from a reticular formation in the region of the brainstem. You can see that it also can either facilitate or inhibit the activity of the alpha and gamma motor neurons. Now you will say, where do we have alpha and gamma? You remember I told you that in the explanation in my offline videos that alpha and gamma are the two types of neurons which are present where? As a part of the anterior root of a spinal cord. Yes? And in the case of the real lower motor neuron that we had there, it was mainly the part of the alpha type of a motor neuron. Do you remember? And as a result, you see, it is still associated with the reflex activity and some regulation of the voluntary type of a movement, but it's not that much conscious type, you see? That's the main idea here to remember. The same with a part of a tectospinal type of the tract. You can see, again, it is associated with the movement, but to the visual stimuli. Okay? And as you can see, they are very much associated with the sympathetic neurons. And as a result, if you remember, we were talking about this tectospine, the pretectal area as the part of what? Of the movement, yes. But of which portion? The parts of the constrictor pupil muscle, yes? So is it conscious again? No. You see? The next portion, what you see here, is a part of a rubrospinal tract. So which acts again both on the alpha and a gamma motor neurons as it was in the case of a reticulospinal tract, you see? And as a result, again, it can be doing important thing. That from one side, you can see that it can be facilitating the flexor muscles and inhibit the activity of the extensor muscles, or with the ones which we call the anti-gravity muscles. Yes, with the ones in the standing. But do you do it yourself consciously? No. Yeah, that's why this part for now is not important for me. When we come back to all of the parts of a brainstem more in details, like reticular formation, like the red nucleus and so on, that's where we'll go through that part, because it's not conscious. I'm not even talking about the vestibulospinal pathway, for example. Yeah, again, it is acting on the lower motor neuron. That's nice, but it's not acting consciously. Yes, it's not in reality volunteer type of the function. Yeah, you see, the same olivospinal type of a tract. So, and even there is even a big doubt that there is any type of this pathway or not, and there is any influence or not. Although we still saying, if you remember when we're talking about the part of the brainstem, particularly the medulla, we still said that yes, we do have some propagation of information with the help of the cerebellum, but that's the question, either yes or not. And a part of a descending autonomic fibers, it's already the word autonomic for you. I do believe it's clear that we are talking about the involuntary type of the control, yes? And this is the part of the autonomic nervous system. So that's why I told you I need corticospinal pathway, which is associated with the primary motor cortex, where particularly we have the formation of the impulse, which is voluntary and which is conscious. Okay? So to continue to see these pathways, how they look like. No, sure not. I didn't even explain that in much details that, am I right? So as a result, what do we have in this case is that, no problem. So in this case, what do we have? They show you the transverse section of a spinal cord. Do you see? And in this transverse section, they just subdivided the parts into the portion of the anterior region, yes, the lateral region, posterior region, you see? And they show you the different ways where do we have the parts of a corticospinal pathways. One, as well as the other descending pathways. And as you can see, most of them are associated with a part of the anterior white matter. And it's even logical because you see how they are starting to associate with the internuncial neuron, with the second order neuron of the simple corticospinal pathway. You see? Okay. So let's continue. What do we have in this part? So we start with a portion of the corticospinal pathways now. So what do we have here? Let's go through every and each of the sentence so to have no questions in this case. So the fibers of a corticospinal tract, as you can see, arise as the axons of a pyramidal cells. Do you remember these? We remember that we've talked about the pyramidal cells, which we said are the one of the largest type of neurons, yes, in the cortex. And that mainly they are associated with which particular layers? What do you remember? What layers we had the most prominent in the case of the motor cortex compared to the sensory one? How many layers do we have? We have 6 layers, yes? Good. So now the question is, what are the most prominent layers in the case of the primary motor cortex? And what are the most prominent layers in the case of a sensory, somatosensory type of a cortex? What do you remember? Guys, I even put it for you here. Do you remember? The part of the cortex. I gave you all of this information. Just a second, this is the encephalon. Yeah, here they are. At the beginning, we were talking about the types of the cells here. Please memorize them better, you know, because it's important for you. All right. So as the result, we had particular 6 main layers, as you can see, yes? Starting with the very first one, which is the type of the molecular layer, yes? The most superficial here. Sorry. I'm sorry. Okay. Next one was the external granule, which was the second one, yeah? Why? Because we have mainly here the type of the cells, which are stellate cells as well as some pyramidal small cells. The third one was external pyramidal layer. Do you remember that? Why? Because here we do have the pyramidal cells, which are maybe not that large, but we said that as we are more deeply passing through the layers, you remember that, and even through the third layer itself, we had larger type of the cells closer to the more deep border of the layer, yes, rather than the superficial one. Then we had the fourth layer here. Do you remember? Granular cells again here in this case. Then we had the fifth layer, as you remember, which is the internal pyramidal layer. And that's where, particularly, we do have a very large type of a pyramidal cells, yeah? That's true. One of you told me now, Arike, I do believe you said the Betz type of a cells, yes? Although the Betz type of a cells, I told you, although, yes, they are present here, but in reality, they are not too many, yeah? Mainly, we have here the medium-sized pyramidal cells. Do you remember? Yes or not? I do believe you remember that, yes? And as a result, we do have the lowermost layer, which is the multiform or polymorphic type of the layer, yeah? And then we said here that although most of the parts of the cerebral cortex normally should be homotypical, meaning that it should show us the classical representation of the 6 layers, but we said that still, in case of the a motor cortex, primary motor cortex particularly, and the somatosensory cortex, we have an exception, and that's what we call, as you can see, heterotypical, yes, cortex. And what do we have in this case? In the case of heterotypical, we can have either granular or agranular. And I do believe it's clear why we call it like that. I even told you that. Granular means that we should have the, what type of a cells? Stellate, yes? That's why it means, where do you have them the most? In the part of the 2nd and the 4th layer. You see? As a result, it's written for you here that a part of the post-central gyrus, which is mainly occupied by the somatosensory cortex, where you have all of these ascending pathways which are mainly entering, yes? So it will be spinothalamic or dorsal column medial and mescal pathway. That's where you will have it, because the 4th layer is the one which gets the whole information. Yeah? Vice versa was happening in a case of agranular type of the layer. And it's still heterotypical. Why? Because in this case, you have a prominence of the layer 3 and 5. And where do you have it? In the precentral gyrus mainly. And some other parts of frontal lobe. Why? What was the function of the precentral gyrus? What type of the cortex you had there? Thank you, Kumar. It was motor. That's why coming back here, this one sentence is already clear for you that fibers of the corticospinal tract arise as axons of the pyramidal cells, and that's true, situated particularly in the 5th layer of a cerebral cortex, which is one of the most prominent, by the way, there, yeah? And as a result, they show you here that out of all of the fibers that we have, you see that 1/3 of these fibers are originating from the primary cortex. What was the primary cortex? The one which we had in the precentral gyrus, yes? And even they show you here the Brodmann areas number, which is the number 4, as you can see. Yeah? You remember? As well as you do have a part of a secondary motor area. And this is particularly the area 6, Brodmann's one. And even there is some origin from the parts of the parietal lobe. You see? So as a result, one thing what you already remember about the corticospinal type of a tracts is where they are coming from. And you already understand why they come from there. Okay? Now, you see that this particular sentence is also should be known for you, because electrical stimulation of different parts of a precentral gyrus produces movements of a different parts of the opposite side of the body. So what it means, we can represent the parts of the body in this area of the cortex. And here comes this idea of homunculus. Do you remember? Do you remember this subdivision? And I do believe I have it here, this homunculus. If I remember correctly. Yeah, here it is. And as I told you, if you remember, mainly there is no any difference between the part of the motor or the somatosensory cortex according to the subdivision of the homunculus, yes? Where, please remember, and this is important for your midterm, by the way, that where you do have a part of the oral region, then the part of the face that is more laterally and inferiorly localized, then we do have more superiorly the part of the upper limb, and you can see that particularly the hand has one of the largest area, which is clear because the very first sentence about the descending pathways told you it is about the corticospinal pathway. It was said that there is a discrete type of the movement, particularly associated with the distal part of the limbs. Yes? And then it comes the part of the wrist and elbow and so on. And so lower limbs are mainly associated with the most superior and the medial part here. You see? Now, the next portion, what do we have in this case is that note that the region controlling the face is situated inferiorly, what we said right now, and the region controlling the lower limbs are situated the most superior and the medial surface of the hemispheres, which I want you to remember because maybe I will ask you that. Now, the homunculus is a distorted picture of the body with the various parts having a size proportional to the area of a cerebral cortex devoted to their control. And this one is also clear already, I do believe, yes? And it is interesting to find that the majority of the corticospinal tract fibers are myelinated and are relatively slow conducting small fibers. You see? So as the result, you can see here that when in the part of the guyton, let me show you it. What was the question? Sorry, let me recheck, please, the question. So if someone undergoes an amputation, is there a reduction in brain activity of that area? You know what? The very interesting thing is that in the case of the amputation, we do have sometimes the even exaggerated type of the activity, but mainly of the sensory cortex, you know? And as the result, what is happening, you know, we call it the, if I remember correctly, the syndrome of the phantom limb. You know, yes, the phantom limbs. That's the idea. Because like you remember that any type of a sensation, yes, I mean the sensory modality, we are identify not by in reality by the body, yeah, it is perceived by the somatosensory cortex. So the activation of a somatosensory cortex, not through the some part of the body, I mean simply like excitation of it, can give the senses like of pain or burning type of sensations sometimes, you know, and so on in case of the amputees. You see? So even if we do have there the activity, just simply we cannot perform it by the limb itself because there is no limb, you know, but there is still propagation of the how do we call them, of the impulses. So what I wanted to show you here, why I entered in this part, just a second, I wanted to show you something in this case. What I was talking here. Yes. Sorry. I realized now. Just a second. Okay, not here in the next this one. You see that when we talk about the different types of the myelinated degree of the level of the myelination, let's select that correctly, yes, in the part of a corticospinal pathway, okay, the one of the biggest that we have, it's a lower motor neuron, you know, because compared to that much to the upper motor neuron, you see, heavily myelinated are the more fibers which are in the periphery, the ones which are, as you can see here, associated with a part of the skeletal muscles, rather than, because this one sentence was very much interesting for us, they are myelinated, but compared to the element, you see, they are relatively slow conducting fibers. Plus, it's not a part of periphery, it's a part of a central nervous system, yes? And in this case, the type of the myelination is different compared to the periphery. Even the cells there are different, yes? In the part of the periphery, we mainly have what type of cells? Schwann cells, yes, for the myelination. In the case of the central one, what do we have? Oligodendrocytes, yes? Is that clear what I'm saying or not? Guys. Good. Now let's continue then. Is it okay if we are going like that? Okay. Here comes the idea where they go through. So in the descending fibers, as you can see, start to converge into one structure, which we call the corona radiata, and then pass through the posterior limb of the internal capsule. And here, I don't remember if we have this good picture in the case of the figure 421, because it has a very scarce pictures, to be honest. And just a second. You know where we can find it? Well, this will be in the, because we are still in the cerebrum. Yes. Let's see these nice pictures here in the portion of the 7. Not here, not here. Here's the encephalon, everything. Here comes the hemispheres. I have this one picture which I love very much, although sometimes students are that much, it's not clear that well, but do you remember this picture? What was on that picture? What was this picture about? It was the cross section, am I right? And on the cross section here, what do you remember? That we saw the portion of the how do we call it? The portion of the gray matter outside, which is the cortex, which we said already, this 6 main layers. But then we said about the part of the propagating fibers. Because if we say about the corticospinal pathway, yes, so it means that we are talking about the white matter already, even in the central nervous system. Is it clear what I'm saying, where I'm going through or not? I do believe it's understandable, yeah? So then, if we are talking about the part of the pathway now, yes, a white matter, it means that it should be in the interior of the how do we call it? In the interior of the cerebrum. So as the result here, it's better seen, the corona radiata unfortunately is not seen very well here, but the part of the internal capsule, as you can see here, the part of its anterior and the portion of the posterior limb here, they are seen very well. Yes? So because saying that we do have particularly the passage of the corticospinal pathway, so this first order neuron, okay, from the beginning it was clear it came from the 5th layer, all right, but then where it goes to? So as a result, then it goes to the part of corona radiata. I will try to find it here, we'll show you. And then the corona radiata simply continues to the part of the internal capsule. Okay, so this particular region. Just a second, let me recheck if I do have here the picture. I don't remember if we have a picture of the corona radiata. Okay, here we do have this portion. Last page, is it there? Ah, yes, like a fan-shaped structure, yeah? Yes, by the way, just to see it again, look. The part of the fibers, do you see? So as a result, the part of the, how do we call it? The internal capsule, you can see here the portion of the corticospinal fibers. Do you see where they are? Yeah? And as more they are medially localized and anteriorly, this is more coming to the part of the head, neck, then the portion of the upper limb, then the portion of the trunk, and then the portion of the lower limb. You see? Yeah. Here they are, but it's not very well seen how it is associated with a part of the um, internal capsule. Just a second. We had somewhere a better picture. I just want to show you it, how it looks like. Let me see here, okay? Okay, just to make it clear, this is the same picture, but yeah, here it's better to see. Look. So, when we said about the parts of the cortex, do you see here? So as a result, you see how the fibers are passing. So they are converging. That's why they told you they are converging to the part and the structure of the white matter, which is the part of the corona radiata. Unfortunately, it's not seen very well. And then going to the part of the posterior region of the internal capsule. Is it clear now how it goes through? Was it understandable? I do believe now it's very clear, yeah? Okay, let's go through the part of the tract. What was the page? Unfortunately, I didn't remember, but okay, no problem. Whew. Yeah, here it is. So what do we see in this case? To continue. So the descending fibers converge in the part of the corona radiata, as you can see, and then pass through the posterior limb of the internal capsule. So it's clear now. And how it was also passing was also clear. Why? Because we saw how even the fibers from which are innervating the different parts of the limbs were mainly associated with the different parts of the internal capsule. Do you remember? Now, here the fibers are organized so that the closest to the genu are concerned with the cervical portion of the body. It was clear, I do believe, while those which are situated the most posteriorly are the ones which are associated with the lower extremity. Yes, yes. The tract then continues through the middle 3/5 of the basis pedunculi of the midbrain. Do you remember that part of the midbrain where we had this portion? On the cross section of the, okay, let's see if it's seen here well, but if not, I will show you that from my presentation. Do you remember from my presentation the cross section of the midbrain? How it looked like? Do you remember that's where we had the crus cerebri? That it was subdivided into several parts? Where here the biggest portion, that's why they show you demarcating here. Look. That's where they show you the part of what? Of the corticospinal pathway. Even here, no, it's not the part what I need. This one, this is body systems 2, if I remember correctly. Let me show you in the presentation of the brain stem. That's not updated one, but it's okay. I didn't change it. Yeah. So the midbrain, where it is, down. Here it is. Do you remember this picture, or do you remember this picture, for example? Do you remember this crus cerebri part? Here, substantia nigra, as you remember? And that's where, particularly, we do have a part of a corticospinal pathway. Here and here. Yes? Is it clear now or not? Is it understandable what I'm talking about, or not that much? I do believe it's clear, yeah? Okay, let's continue with that part. Then, And here they tell you that at this region, at the part of a midbrain, the fibers concerned with the cervical portion, so more upper part, yes, of the body, are more situated medially, and the ones which are associated with the more lower regions of the body, they are situated laterally. You see? So at the level of the internal capsule, you remember, it was anterior to posterior, or to say correctly, anteromedial to posterolateral distribution from head to toe. In this case, it is medial to lateral. Okay? Is it clear or not till now? Yes, no? Guys, tell me something that I would understand. Now, on the entering to the pons, do you remember the part of a pons? We had there the tract which was passing through where it was anteriorly. Do you remember? But it was broken by what? By these pontocerebellar fibers. And here again, in the part of this presentation, at the region of the pons, if you remember, that's why I was telling you, look very precisely, like what should you have at the level of a brainstem, yeah? And here they are. They are here, and that's why they are broken by the transverse pontocerebellar fibers. Do you see how they pass through here? So they are breaking these bundles of the corticospinal pathway. Okay? Now, next portion, what do we see in this case? That now in the medulla, you remember we've talked about the medulla, that in the medulla, the bundles become grouped together again because nothing now is simply breaking them into the pieces. And here, if you remember, we said, where should we have the part of the corticospinal pathway? It was anterior, yes? And that's where we had even projections on the anterior surface of the medulla. That's what we even called the pyramids. Do you remember? And that's where comes really this name, this alternative name, as you can see, the part of a pyramidal tract for the corticospinal. Okay? And what was important thing here, because this everything on all of this pathway till now, it was the first order neuron. It was the upper motor neuron which was passing through all of the structures. And here comes important thing. I told you that in the case of a descending pathways, in the case of a corticospinal pathway, we should have the decussation. And this decussation we also have seen at the level of the medulla, particularly the inferior most level of the medulla, where we have the part of the junction between the medulla and the spinal cord, yes? And that's where you have it, that at the junction of the medulla and the spinal cord, most of the fibers are starting to do what? They are crossing the midline, and as a result, we call this region the pyramidal decussation, or decussation of the pyramids. And in this case, what do we have? These are the biggest portion of the whole corticospinal pathway, which is then, when it enters towards the spinal cord, it enters towards the lateral white column of the spinal cord. You see? Is it clear till now? The other parts, what is left here, a small amount of the fibers. So these are the ones which are not decussating most commonly. And as you, sorry. Oh, I'm sorry. And as a result, without any decussation, without any movement towards the lateral surface, they are mainly going towards the anterior portion of the white matter of a spinal cord. That's why here you can see that these fibers eventually cross the midline and terminate in the gray, in the anterior gray column of a spinal cord segments. But where? Most commonly, these are the most upper ones, okay, which are not associated that much with the upper region of the and the movement that much of the upper limbs, sorry. You see? And as a result, that's why they showed you here. Just a second, let me show you this picture. Here they are. Look. So the part of the corticospinal pathway, you see, they even didn't show you here that they are still having some decussation, but they still do. And as a result, we do have the pathway, which is the corticospinal, which is giving us the innervation of the skeletal muscles through the portion of the neck, upper limbs, the torso, the lower limbs, the part of pelvis, and perineum. Is this part clear till now or not? If it's clear till now, let's have 5 minutes rest, okay? It's like right now 18:11. Just 5 minutes, please. I need to drink the water, and then we can continue, okay? Okay, I will stop recording, just not